Hello, everybody. Welcome to Pej's Recovery Corner. This is a recovery podcast. We are back. I haven't been on the air in about 9 months. We revamped this new studio, and I wanted to bring a very special guest on today. First, I do want to describe the podcast. It's a recovery podcast. We have various guests from all walks of life that their lives revolve around recovery. Some of them are addicts, former addicts, or alcoholics that are in recovery, people with mental health. And I often love to bring professionals on, people that work in the field of addiction and alcoholism and mental health, and have firsthand experience and hear their outlook. So I'm very, very blessed today to have been introduced a while back to Dr. B. Dr. B works in the field of addiction. You're an addiction doctor.
That's right.
And it's, who better than to have you as my first guest? So I wanted today's topic is Tranq Dope that's out there on the streets right now. You want to go right into it, and let's talk about Tranq, and I'll ask some questions too.
Sure, we'll get into it. I know we are on live on multiple platforms. Some of yours, Facebook, YouTube, and mine, Facebook and YouTube. Hi, everybody out there. I'm so happy to be back on. I'm wondering if it's okay with you. Some of my viewers probably don't know you, and we have known each other sort of by in some bizarre ways for quite some time.
Sure.
We have mutual friends. We have mutual kind of business associates, I think.
Yes.
Do you mind? I want them to know a little bit about you, what you do right now, at least my viewers, and maybe some of your viewers. And I'm on TikTok as well.
Okay.
So I want to say hi to everybody. I want to do these lives more often. I'd like to maybe do more stuff with Pej as well. He's really good stuff. So to the extent that you want to, tell us a little bit about you, and we'll get warmed up.
So I am Pej. I am an Iranian American that was raised here in America since the age of 5. I have been I'm in recovery myself. I'm coming up on 16 years in June. I was a very, there was a lot of trauma that was in my background, but also a lot of drug use, a lot of alcoholism and things like that. So I got sober because I was there was a soul sickness. There was a lot of things that had happened to me throughout my life that should have got me sober, but I just got to a point in my life where I wanted to get help. And when I got help, I went in through a recovery home. It was a Persian recovery home. I actually went to make the Persian family happy in the beginning, but almost immediately I was taken out on these adventures where we were doing interventions on people. The people that were my mentors were kind of demonstrating what it's like to go into a family setting, a family system, and seeing how family dynamics function and how somebody's loved one might be enabled or might be living in a certain type of environment where they're probably not going to get better because the family's kind of just as sick as them. And so early on, I just was really turned on to trying to help people. And so I went to school. I went to college to learn drug and alcohol studies. I wanted to become a counselor, a case manager and a counselor during that time. Finished top of my class, never did good in school before that because I was always under the influence. So lo and behold, when you get sober, you pay attention in class. You actually get your assignments done. You do well on quizzes, and that's what happened. I got on the dean's list, and I started working in addiction treatment almost immediately after finishing school. So I worked in adolescent facilities, and then I worked in adult treatment too. And on the front lines, I'm talking, I've held every type of position outside of being a therapist in the treatment system. So I've been a tech, I've been a case manager, I've been a program director, I've been admissions counselor. And then later on, I got into intervention work. And when I went into that realm of this type of work, I wanted to pretty much be out there and help people get the help that they need, whoever they are, whatever their purpose is. So I started doing that professionally. I was taught under the direction of a world-renowned interventionist named Earl Hightower. He's still my mentor to this day. He showed me the ins and outs, the do's and the don'ts and then I went and did intervention studies extensively. And, again, I already had been doing interventions under the direction of Earl, but then now I'm almost certified. I will be a certified interventionist probably within a few weeks. but I've been doing interventions for at least 10 years.
Wow.
Now, also, I got into through mutual friends that we both have. There's somebody that I used to have a podcast with, and he started another company, and he kept telling me, Pej, you need to get into the TikTok space. I'm like, that's for kids. I don't see that going anywhere. I don't know. He said, actually, your message is a strong message, and it will be carried a lot farther than what you're doing right now when you're limited to places like Facebook and such. But I told him, okay, let's give it a shot. And I got into the TikTok world and then YouTube world. And next thing you know, within a couple of years, consistently making a plethora of videos in relation to my experiences, my personal experiences, or what I have seen with people that are suffering from addiction, alcoholism, and such. I just made a lot of videos, and now I'm recognized by mostly the youth. Like, there's a lot of young people that are often turning to me for direction in life. A lot of them are going through that curious phase, the experimental phase. Some of them are actually getting into heavy substances and questioning, should I be doing this? And so they often turn to me for counsel. A lot of them will ask me questions, or I'll see people in public. They say, I know you from TikTok. Aren't you that guy? But we started a podcast with that particular person where we wanted to get our message out there before, called Sober Grind. But then when I kind of went solo and wasn't attached to a treatment center, I started my own podcast during the pandemic called Pej's Recovery Corner. And it was kind of just out of an office that I had, and I would have guests on, and so for a long time it was running. And then I wanted to actually have a studio, a place where it was more of a comfortable setting, and we could sit with guests and talk to guests like yourself, such as yourself, and be able to learn. I'm all about educating, teaching, and learning, and also I believe sometimes some of the best experiences that people can relate to is people's life experiences.
Sure.
So that's who I am. I was a little drawn out, but now let's talk about you and what you do, and also we can get on the subject of Tranq.
Sure. We were going to get on Tranq, guys. I promise. Nicole's out there. Your questions will pop up. We have an hour and a half today. I'll talk about me briefly. I want to just add a little something so it sort of ties this whole thing in for those of you that have seen my lives. As you know, I don't do lives with too many people because I'm very particular about who I'll go on live with. Most of you out there know Dodd and Parham. Parham is the psychologist that all of you ask me about, or come into my office at times, or send me emails. Well, there's an interesting connection here, and a lot of you know about Parham's background. These two guys got clean together about 16 years ago.
We did.
Okay, so there's no financial relationship at all between the three of us. It's just simply mutual respect. And regardless of how we see things, I think it's our moral compass and approach to substance abuse, to people dealing with it, what one is supposed to do, and just a general mutual respect all around. And again, this is the first time we've met in person, but I've known about Pej, and I also have known about his TikTok, his YouTube, all the other stuff, and I always watch it. So that's a little bit of background to tie it all in. Me, him, and Parham, the super therapist, we all have a relationship here. As far as me, for your audience, you basically said I'm an addiction medicine doctor. Historically, for most of my career, I was an academic emergency physician, and I worked at I was a professor of emergency medicine. I saw patients, I treated patients. I trained doctors, medical students, graduate students. I would do research and so forth. Several years ago, and people say, well, how'd you get into substance abuse? Well, part of what you do as an emergency medicine physician, if you're really doing real medicine, is toxicology, and a subfield of that is substance abuse, overdoses, and so forth. There's other places where I get digging deep into that, of how that I really got pushed into this. But at some point, about 5-6 years ago, I left the academic university world and went into private practice. I don't really work, and I don't do any medical directorships with any programs or detoxes and so forth, because I don't want to. I started a lot of my own programs. I had a nonprofit IOP. I had a evidence-based re-entry housing instead of a sober housing, which really dealt with youth at risk, kids coming out of juvenile hall, guys getting out of prison. But at this time, I strictly run Zephyr Medical Group, which is a dedicated substance abuse medical office. Let's get started with Tranq Dope. Tranq Dope, it's the new thing everyone's talking about, huh?
So, I've heard of Tranq now for a few months. Obviously, I'd heard that it actually kind of hit the streets and originated probably in the Philadelphia area, if I'm not mistaken, and now it's kind of migrated and it's made its way around the United States. More recently, just last weekend, I was doing an intervention in Hollywood, on the streets of Hollywood, with a homeless couple, and the young man was talking about this flesh-eating drug that's out there and how he's trying to avoid that, but lately it's been it kind of gets mixed with fentanyl even for that. Like it's all. So tell us about Tranq. Like what? Because you're the doctor and you know exactly what it is. It's the name, the actual name of Tranq, what it originates from, and what it does.
Sure. Tranq is a reference to tranquilizer.
Yeah.
Excuse me. And in particular, it's referring to the component of Tranq Dope, which is called Xylazine. I forgot what someone out there could remind us what the brand name of Xylazine.
Yeah.
And Xylazine, an animal tranquilizer, and Tranq Dope is a mixture of Xylazine and Fentanyl. And that's what they refer to as Tranq Dope. I want to add to something that you said. It didn't originate in Philly. In fact, this stuff has been around for over 20 years.
Okay.
And it originated with the Puerto Rican community, and in fact, was probably misuse, and abuse in Puerto Rico or the immigrant community here. So it's been around.
Well, I was going to say it's reminiscent of crocodile.
That's right.
Which was obviously in Florida for a while. But also, I know that in Iran there is a certain type of drug that's flesh-eating called kerak. They call it kerak, which sounds like crack, but it's not crack cocaine, right? It's a combination of certain drugs, and I think a lot of people that are addicted, that get addicted to it, over a period of time, they're using it and they're not conscious of what's happening to them physically, mentally, and then all of a sudden, parts of their limbs and things like that are getting highly affected. So it seems like these drugs are along the same lines.
I don't know what that drug is, but I will. But let me. I'll get into that flesh-eating thing.
Yeah.
And I think one of the great things about when we do output like this,
yes.
I want to. Not only am I fighting to decrease stigma on people, the way people look at substance abuse clients or addicts or whatever you want to call it. I try not to use the term addict because I think that stigmatizes.
Sure.
But I want to dispel myths. There's no mysteries in this world, right? And and I think the way this stuff gets into the media and gets out there,
right?
We're already suffering from lack of meaningful, formal, evolved information in all areas of our life.
Right.
And in this one area, I want to try to dispel myths when I can. In substance abuse. So first, and I'll get to that flesh thing. First, it's Xylazine. It's an animal tranquilizer sedative. They cut it with the fentanyl. Why? Because this stuff is easy to get. It's not even FDA. It's not even DEA structured. So as an animal veterinary medicine, it's pretty easy for guys to get. That being said, there's no super labs or crappy labs. It's pretty easy to get for these guys, and they're probably cutting it with the fentanyl, getting it out there, and it's easy to do. And this, you're going to see permutations of this over. I made a video a couple of years ago. The new drug addict, 50 years ago, that was the heroin addict, or 60 years ago, or 70 years ago.
Sure.
It was a beatnik guy. It was a guy that was reading Allen Ginsberg, William Barrows, sitting in some place drinking coffee. The meth, stimulant, speed guy was a Caucasian gang, biker gang guy. Very different socio-cultural dispositions, attitudes, and subcultures. That's no longer the case.
Yeah.
Drug addict, someone who's using drugs, man, everything goes in there. That itself, its own phenomena that takes quite a bit of sociological and psychological exploration and approach to treatment. I'll leave that aside. and I think at this point you asked about the wound thing. Again, let's step back and look at the historicity and evolution of wounds and drugs.
Yes.
What people don't realize is anybody putting a needle in their arm has been suffering as a secondary consequence of that, of getting wound infections and a whole bunch of other stuff, endocarditis, blood infections, septicemia, and so forth. This has been going on ever since, whether you're putting meth in your system or heroin.
Sure.
Then with fentanyl, they, when people started to use it on the street, there was this like, oh my God, the number of, people are getting more wound infections. Now, you can't attribute that necessarily to the fentanyl. There's a difference between association and causation, right?
Yes.
It could be because fentanyl is short acting and the user's dosing more times through a day, you're creating more friction, more trauma, more events where you have contact with the skin, and the risk and rate of wound infections goes up.
Okay.
Right? So we want to keep that in mind. Now we bring this thing in. We got to look globally at this, right? The average person that's taking something like this and putting in their arm, they already have a weakened, decreased immune system in general. They already have poor access and poor volition and will to seek medical care, have good nutrition, right? Respond to their most immediate physical needs. So they're already much more susceptible to infections as it is.
Right.
Now let's move. Is xylazine causing this, right? And what do we know about xylazine that could be potentially causing this? Thus far, the only thing that I can say is that because it's this thing called the alpha-2 agonist, immediately it has a local vasoconstriction effect, which means the blood vessels narrow.
Okay.
Well, when your blood vessels narrow, potentially, again, some of this theoretically, because when you talk about a diabetic person with peripheral, vascular disease, they're going to have foot infections, right? Blood flows less down there, a bunch of other stuff too. But now you can't get the immune cells down there. You can't clean things up. In that same sense, there could be some local effect from someone who already has a debilitated, weakened immune system. And when you get that vasoconstriction, the blood vessel narrows, you're not getting the blood flow to fight off infections. And that's one possibility. But, you start to hear, well, people are also getting wounds elsewhere with this stuff, right? Intravenously. That's interesting, right? So let's say you're banging dope in your arm, but you get that wound in your leg. Okay. So you look at that guy again. You're wondering, well, there's lifestyle issues, there's environmental issues, there's a general approach to their own health that's already debilitated. We want to keep that in mind. Then I do know that in certain places, the guys that are dealing with this stuff are recommending people as a harm reduction approach. You know what? Snort this stuff or ingest it. And I don't want to talk about too much about the number of ways you can take this, because I don't want to teach anybody anything. But one of the things those guys are doing is telling folks, dude, stop shooting this stuff. Do it this way. That being said, I've also heard reports, and we call this anecdotal evidence in medicine. It's the lowest form of evidence, but it doesn't mean it's crappy. It just needs to build up. I'm getting reports that even folks that are snorting it are getting wounds elsewhere. I don't know how true that is, but it's something to keep in mind. If you're injecting something in your body, at the very least, you're susceptible to an infection at that local site. You get an infection because of your environment. You're already susceptible to MRSA or other resistant medications, and you're not getting good wound cleansing or clinical care, and you're not seeking help. But it gets a little complicated in this picture because we're also saying people that snorted, it shows up elsewhere, and so on. But really, so that's that. And the wounds that are presenting, just so everyone knows, these aren't any kind of special particular wounds that are particular to this issue. These are the range and spectrum of soft tissue infections that anybody gets from different reasons, right? But the end stage of the wound is the same as far as biochemically, as far as physiologically, and the treatment is the same as any chronic wound one have. In fact, some of them that have eschars at the end, that's the same as a wound that has been burned that's healing. So these are amendable to clinical treatment, and they've been having success. but I think the patient's already debilitated. So it's a wound. I'm not sure why it's being caused. Certainly there's an association with xylazine, but I want to take away some of the stigma and fear that people might have from someone that's using, you know, in the same way they're like, oh my God, don't touch him. He used fentanyl. You'll overdose. No, you won't overdose. Get first responder there, start CPR, get this guy to the hospital, and don't be insane, because in the physical universe as we know it, or any other dimension, you can't get fentanyl overdose by helping someone that's been overdosed from fentanyl. That being said, that's all I want to do in this case, is decrease the stigma on that. And I hope I answered some of your questions on that.
I think you answered my questions very well. So that's really good insight. I mean, it's so good to hear from somebody that's actually. Have you had any patients that actually have used Tranq?
We have not yet. I suspect at some point here, I'm certainly educating my staff and so forth on it. You told me, and I think someone else, it's showing up in Hollywood. It's certainly made its way, and it's making its way across the country. And I'm sure I will have them, because in the Santa Ana area, there's a lot of junk going around.
Right.
So they're going to present, and my staff is fully educated and
ready. Like, we're pretty much ready to see it.
Probably. Yeah, but we're ready to see it. And you bringing that up, I want to bring up one other thing about how Tranq went from, being in the community early 2000s, and what actually happened is they started to note an increase in overdose deaths, especially in the Philly area, and, something going from like 2% to 30%, whatever that had xylazine in the dope.
I saw some of those.
Yeah. And those numbers were climbing radically. And I think that's what brought it to the forefront, in addition to the experience of the front guy fighters and seeing that. And this stuff, you can't test it, on the typical. And it might have been around much longer, because you got to send this stuff to the lab, get chromatography. There's no point of care urine testing for it. You got to be looking for it, and you got to order it, and you got to wait a week at this time. This might change in the future to get this stuff. So I might be getting urines that already has Tranq Dope in it, but I can't pick it up. But I'm certainly aware of it. And I just wanted to add that part.
That's great. A lot of people ask, where does this stuff come from? Who's making this? Who's distributing it? Obviously, if there's a book out called Fentanyl Incorporated, right? And it talks extensively about how, fentanyl's been around forever, since the 60s, I believe. And it's used in a surgical process usually, or in a doctor's care.
Yeah. So procedural sedations, but I used it a lot myself in my career, because that stigma on fentanyl. I'm like, dude, this stuff is amazing. What's wrong? When I first kind of hit the street,
sure,
there's a place for it. It's short acting. It gets out of, if you came in and you were a victim of a motor vehicle accident,
sure,
and I gotta sedate you, I gotta put you intubate you and so forth. I do my thing, save your life, get you going and so forth. I want some pain control. But the neurosurgeon's going to come in about 45 minutes, and he needs to do a minimal neuro exam, and we need to do a coma scale. Well, fentanyl is great. You know why? When I turn it off, it doesn't take long to get out of your system.
Right.
So there's many places for it.
Sure.
So, I digressed on fentanyl. But.
Oh, I get it. It serves its purpose in a medical setting, most definitely. What I started seeing, because I've been working in addiction treatment for almost 15 years, right? And I saw probably about 12 years ago, we were starting to get patients that were coming into a treatment setting that had been abusing their fentanyl patches and their fentanyl lollipops that were prescribed to somebody else, sometimes even to themselves. And some of them were opiate users, so it was easy to abuse what they were getting. The praise that we really started seeing more was in the last 6-7 years, where and it wasn't through these fake blues, the M3s that are out there, but it was more people were really using fentanyl in a powder form or rock form, right? So distribution of that, a lot of people theorize, or actually it's factual that it's from China, or it's also distributed through South America into America. But it's out there, and now with a drug like xylazine, which is actually, it's used in a veterinary setting. And I don't think that it's regulated right now, right? Like you had mentioned.
Yeah, it's unlike most sedatives, hypnotics, pain medication, analgesics, even in the veterinary setting that has some DEA regulation like human stuff. This particular one doesn't. So it's much easier for folks to get from the manufacturer, because now it doesn't have that second layer of, which is probably going to change soon. Doesn't have that second layer of protection. Let's say if you wanted to get carfentanil, right? People call it elephant tranq. It's related to fentanyl.
Sure.
If you want to get that, that's hard to get, right?
Yeah.
But this stuff has been easy to get.
So my whole thing of when I hear about, people ask me all the time, so how's this stuff, like, where's it coming from? Who's getting it out there? If you look, like, within the last 24 hours, there have been tranq busts in mass quantities, and you're seeing them in a pill form. And one has to wonder, like, so who comes up with these bright ideas to mix the two, right? The way the kid described it to me, he's a 23-year-old kid, and he's doing fentanyl right in front of me, saying he's just not ready yet. I mean, I've been working on this case for a little while, trying to get him and the girlfriend to have this realization, like, this lifestyle is not going to bring you anywhere. You're going to die out here, right? Like, you're not even from the state, and you're hanging in areas where it's dog eat dog. They're going to get phenomenal. And they tell me things like, like, I'm not doing, I have what I do is under control. I'm not like so-and-so that does that tranq stuff that's out there right now. And so I get curious. I'm like, so tell me about that so-and-so and the tranq stuff that he's using. Oh yeah, well, that guy's got all kinds of stuff going on with his legs, and there's sores and things like that. I don't want that stuff to happen to me. And I think to myself, like, these are homeless people that live in tents. Like, who's out there making this stuff and getting it to them? I mean, obviously, it could be from many different areas, but is it a chemist? Is it what do you assume?
Yeah. So I'm going to answer that, but I thought what was fascinating, there's a intrapsychic dynamic going from this person. 2 years ago, this person may have not known about Tranq Dope, and someone would say, dude, you're doing fentanyl. My God, we used to do heroin. That's okay. Yeah. Now the fentanyl guy sitting and saying, I'm okay. He's doing Tranq Dope.
He's minimizing what could happen.
Yeah, and the degree of fantastic delusions that we create to cope with our reality is something of quite interest to me. So I'll leave that at that, and we can do a podcast just talking about that kind of thing.
I'm going to have you on here a lot, and I want to be on yours too.
I love that. But as far as in terms of that, so keep in mind, fentanyl is synthetic manufactured. It's hard to get from the legitimate places. So it is the case that you need a sophisticated operation in China, and that's why it's coming from China. They're saying it's being manufactured there. There's labs in Mexico and so forth. It's a complex drug to manufacture, and I actually think it's silly that you prohibit China's fentanyl manufacturing in any way, because, man, has source suppression ever worked? It didn't work in Colombia. It didn't work with the crops. It didn't work with, you put a Pablo Escobar, or what's his name, the Mexican guy, the big drug. Chapo. Yeah. You're going to spend $25 million in 15 years and get that guy in prison. Okay, this has nothing to do with my judgment of him, but I'm going to tell you this. The next question a reasonable, rational public should ask is, that money spent, 15 years, those kinds of resources, now he's behind bars. My next question is, what happened to the production of illicit substances that he was doing? Is it less? And has substance abuse and overdose deaths gone down? If it hasn't, who gives a shit?
Yeah, you're right.
So that's my thoughts.
Very well said.
We've decided to live in fantasies. That's another issue. Now, as far as this stuff, Tranq Dope, no, like I said, Tranq is easy to get from the legitimate manufacturers. That's number one. Number two, the process is called salting. I don't know if you've heard that with Tranq Dope.
Well, tell us about it.
It's salting. So you get it in chemistry. So, to salt something, salt. It's a crystalline structure, right? They take it out of liquid form. It's very easy to salt anything.
Do they cook it?
No, I won't go through the process, but it's very easy, right? It's simple. You take the liquid, you make it salt, then you dissolve it back into whatever the fentanyl mixes. That's it.
That's it.
So, so they're buying it. Like I said, there's no need for any laboratory. A 2-year-old can salt something. That's the organic chemistry. First, in fact, right, general chemistry, I think. But they're salting it, and then now, who came up with the idea? These guys are sitting around messing around with stuff, and different guys all the time. Who knows? I don't know who came up with it first.
I'm sure from reading that book and just knowing, there's always been chemists that also will experiment with their own experiments.
And for all I do know there's case reports of a couple of vets, animal doctors that were abusing xylazine.
Okay.
These guys were hardcore abusing this stuff. Just like regular doctors, especially anesthesiologists and guys in the ER, are very big on abusing stuff. They have access to it. But xylazine is right there. And interestingly, in the veterinary medicine world, they keep calling it horse tranq. It's a big animal. It's used in dogs and cats too. Yeah. So when you're saying horse tranquilizer, again, you're adding some sort of a mysterious thing to it. And finally, it's really out of style, even in veterinary medicine, simply because there's much safer medications they're using now. And they use it for procedural sedation. Let's say a cat or a dog put its elbow out or needs some sutures taken out. You don't want to bring the level of sedation down to a level where you got to put a tube down their throat because you don't need them for 10 hours to open their heart. You have a minor procedure to do. And it was traditionally used with either fentanyl, something like ketamine, believe it or not. I'm hesitant about saying that. They mix those two, they give it to the person. Now it works as something that sedates you. It's also an analgesic. It's a muscle relaxant. It's a hypnotic if you were a human, probably. I don't know. So they mix it, let's say, with fentanyl or whatever opiate they're using. What that does is create a situation where you can decrease the dose of both drugs and get cross coverage over pain, over sedation, over comfort, and so on. So it's right out there. It's easy to get. They salt it. And I don't think it's very often used with vets. You can ask a vet because there's new and better drugs, but it's still out there.
Okay, so to be clear, because I know you described it so well, but it's actually not when the skin is affected and somebody has those welts or those things that come out from using. It's not from the actual drug. It's from parts of their body that they're not taking care of.
So
you're not certain.
So, and it may never come out, but I can't say for certain that X is causing Y.
Okay.
So I don't think anyone out there right now can say, any professional out there can say xylazine is specifically causing the local tissue necrosis that ends up in a chronic wound. That's all I'm saying.
Okay.
But in some senses, for someone like me, and I also deal with my patients, we take care of all of our patient stuff, including their wounds, chronic wounds, whatever it is. But for someone like me or anybody that's going to manage their wound, in some ways, the question is not super important, except the harm reduction approach. And here's why I'll say that. We're certainly not trying to make it better Tranq Dope for consumption. So, I'm not sitting here saying, boy, I got to figure out what's causing the skin lesions so people can buy more Tranq Dope. That's,
right.
One cent. Certainly, I want them to not get the skin lesions. Other than a harm reduction approach, the wound is no different than any other wound that presents itself in that clinical form, whatever that form is. It's not something weird, unique, and from Mars. That needs to be treated, and you got to stop doing dope, man.
Yeah.
Right?
Okay.
That's it. Right?
Yeah.
Maybe the guy that's selling the stuff is really trying to figure out, man, is this xylazine? I need to come up with a better mixture so my sales and demand curve goes up.
Right.
I don't know. Right. And then there's the guys that are kind of doing a harm reduction approach. Hey, if you're going to bang dope, at least snort it or eat it or something. And now I'm hearing that, well, even if you do that, they're getting lesions at different places. So I don't know. I don't think anyone knows. And in some senses, depending how you're looking at this, it doesn't matter. I don't think we'll ever necessarily know the answer. You can't be doing dope. That lifestyle is going to give you not just those infections, it's going to give you HIV, hepatitis C, endocarditis, other soft tissue infections, you know, assault, going to jail and losing everything. So stop doing dope. You know, and I'm saying that kind of tongue in cheek because that's a big monstrous process to go through. But in some ways, that's how I look at it.
Okay, so in comparison to, remember, it was like at least a decade, maybe a decade and a half ago, Crocodile. And I think it was street name was Flacco. Was that what it was?
Yeah.
No, two different. Crocodile and then Flacco.
Oh, okay. Yeah. Crocodile. So what's the difference between that? Was that also along the same lines?
Yeah, I'm trying to remember what was in, and in fact, I think I have a video on that, and I'm trying to remember what was in. Maybe someone can look it up. What was in Crocodile? I think that was basically stuff made in the kitchen, right? Is that what the deal with that was?
I think I remember hearing that.
And really, again, if I heard there were components in it, again, it could be anything from a local reaction of the soft tissue, because a lot of people were losing. And I think that was particular to the chemical construction of the stuff that they were putting in their body. I'm having a little lapse in memory here because I actually knew quite a bit about how that's presented itself. But I think that was much more so from the concoction in the drug than this stuff.
It's just interesting, you know. Obviously, you know, you were mentioning like the way people got high in the 70s, the way people got high in the 60s, the way people get high in the 80s. In comparison, like there was a surge of like cocaine and crack use in the 80s more, as opposed to like the hippie drugs that were really popularized in the 60s and 70s. And it seems we're in 2023 right now. We've got things like Tranq. A few years ago, we had Crocodile. One has to wonder, like, why would you want to do something that potentially could affect your skin in that sense? I mean, you could ask the same question to a fentanyl addict, like, why do you do a drug that all your friends are dying from? And really, I think what people are really chasing and going after is, how's it going to make me feel? Because I've got a world of issues that I don't want to face. And I want to know what this makes me feel like. Oh, that one's making everybody else die? Give it to me, because it must be very powerful. I won't die. What's the psychology behind it? Like, why would somebody do something like this?
In my humble opinion on these issues, I think that's a great question. And potentially we can move towards podcasts that explore these issues. But over the years, I've developed a hierarchy of the way I approach a patient, and it has to do with that question. And that hierarchy for me is the immediate physical and physiological. I got to take care of that and look at that first, right? That's easy. And some disease processes or clinical pathological processes, that's all you got to do. Let's say you fall and break your leg. I don't even need to know who the heck you are. Just as long as there wasn't any trauma, I could fix that, send on your way. I don't need to know your name, your right. That's an easy thing. It's right there, X, Y, and Z. I follow the algorithm, and I need to know some medical history and so on. Okay. Now we're getting to a very complex model of disease. And I have found over the years, not only do I need to know your physical clinical picture, then I need to understand your intrapsychic dynamics and how you got to this place inside your immediate environment that you came up in. And then, you know, people refer to that maybe, oh, trauma, but, you know, there's quite a bit here, you know. And because for me to create an environment for you to move forward in, even as your, you know, MD doctor for this, I'm dealing with something very complex, and I need to have some understanding and then figure out the tools I have and give them to. But, you know, it goes beyond that. It's societal. And in fact, you can couch this not just in the physical, not just in the individual psychological intrapsychic dynamics, but I have found over the years and have started to pursue couching it. I don't want to say the wrong words, but in some senses, in the fundamental structures that Freud gave us of what intrapsychic dynamics are, and its evolution into whatever you want to say, young objects relations. But I have found the stuff that he said applies to society and gives us explanations for why things go wrong, when there's a pathological process, when there's a nurturing process. So the answer to your question to me is it's not just the individual. Like we are an organism that is evolving in the environment that we come in. And this is an extremely complex and ever-changing environment, society that we're in. And that plays and contributes just as much to what I choose to do in my life and how I choose to kill myself as my own personal decision. I'm not saying it takes away responsibility and accountability. I'm saying that, and I tell people, no, that's on you, man.
Yeah.
Right. But nevertheless, there's no denying, and the literature, I think, really supports this. If you start digging into everything from literary theory to social theory to social psychology to looking at the criminal justice system to political theory, everything goes hand in hand. And we create an environment for the behavior of the individual and how the individuals in that society start to behave. So I think the only answer I can give here now is this is why that I feel in some senses every one of us is accountable and responsible for the substance abuse patient. Every one of us is accountable and responsible for the sex trafficked victim. Every one of us is accountable and responsible for the impact the choices of the alcoholic makes of in his family, because we have collectively, whether consciously or unconsciously, created a social environment and the milieu for that shit to fester in the individual. And that's my answer.
That's a great answer.
It makes sense.
It makes a lot of sense.
Short answer.
You're so well spoken, and it's evident you're so educated, but
you're too kind.
It's deep, like really, it makes a lot of sense.
I appreciate that. Yeah.
And when you say everyone is responsible, does that mean we should be out there educating or helping or trying to raise awareness? What do you think is our responsibility in that sense?
In terms of just substance, because I look at these issues all the same, whether it's our overcrowded prisons, whether it's our inhumane sentences, whether it's the increasing amount of crime. At the very least, everybody should at least realize this and not be judgmental of the drug addict, substance abuse patient. That's all. If there's any one thing you can do is stop being judgmental. And I had a patient actually yesterday who's going through a fentanyl detox, and I was mentioning it to you guys. And I don't know what happened, but presumably this may have happened. And he accidentally took a 50 milligram naltrexone tablet. Within an hour, he was in florid precipitated withdrawal and ended up in the ER. I realized he went to the ER. They looked at him, and this guy was suffering, hunched over, and they sent him home. This is easy treatment. Intravenous fluids, maybe a little bit of Ativan, maybe a little bit of Zofran, right? Maybe 2 liters, and then make sure the guy can get up and walk. His girlfriend had to help him out of the car, ED, and into the car. And I'm not saying that's what necessarily happened last night. I wasn't there, but it's very potential. And if there was empathy, if there was compassion, if there was not any judgment, this may not have happened.
So do you think sometimes when people go to the hospital, they're just viewed as, well, this guy's just got addiction, let's just get him along his way?
It was always not just get him on his way, but one of the things that bothered me when I was in academic medicine, I've told this story before, but really briefly, I remember a guy came in from somewhere like Tehachapi or something. It's a real, and there was a lot of meth labs out there. And this guy used to bang dope in his shoulder. And I remember, in fact, I still have a picture of it. I used to use this for left shoulder. And he showed up this day, and I look, and the whole thing was rotting. and there was a skin graft there,
Mm-hmm.
right? And I said, dude, what's up? He's like, yeah, I came here before because, I used to bang dope up here, and then it got infected. Then I had to get a skin graft. And I see this half skin graft that hasn't really taken hold, and his skin's open. And part of it, I can almost see his bone. And I'm kind of worried about some osteo, which is a bone infection. So I'm like, dude, you got to come in. You got to come into surgery, and that guy has to do this. So I order a hefty. I'm like, how much dope do you use? And he told me, I think at that time he was like, I use about 2 to 3 grams of heroin a day, right? And what am I going to do? I said, don't worry about it. So I immediately put him on something like 8 milligrams morphine an hour, right? As needed for pain. I mean, this is painful, right?
Sure.
On top of that, this guy has a much lower threshold, and that's okay. What the heck's he gonna do? Then I see surgery come on board, and I read his thing, and one of my residents comes up to me and say, dude, this guy's about to bounce. I'm like, what do you mean he's gonna bounce? He's gonna get infection, and he's gonna get. And I go and look, and he's like, they put him on 2 milligrams of morphine an hour. On much lesser pathology, you would potentially give a patient much more than that. Clinically, this guy's pain threshold is completely different than the regular person. 2, he's got serious disease that needs pain control. Yeah, you took those 2 things that you should add up and increase his pain management. You decreased it to a point where he's going to leave and die. It's bizarre how we make decisions. It's none of your business this guy's a drug addict, and you have no business judging him. You are a clinician. You got to do this. You got to manage pain, right? Used to be the 5th vital sign, and you have to do your procedures and send them home well. So yeah, there's a lot of stigma and judgment even to this day in the hospitals.
So as a former drug user and alcoholic, I realized even when we first started the podcast, and you like to choose your words wisely. You don't want to label somebody as an addict. I have often sat in many 12-step groups, and people identify themselves as an alcoholic or an addict. And I think to myself, well, are you currently addicted? Because if you're currently addicted, then you're the addict, right? Or you could say, like, I'm addicted, so I'm an addict. But if you aren't, then you could say former addict. And a lot of people say, well, we're addicts for the rest of our lives. People in many of those communities will talk that way. Like, that's just what we are.
Yeah, I know.
Right?
Yeah.
It's a disease. The disease is always there. Some people will say it's doing push-ups. It's just waiting to get me, this and that. And personally, as a person that has had extensive addiction in not just in my own life, but in my family system, there was, my cousins in Iran who I've never even met in person. They had addiction. So one has to wonder, like, did it just run in the family? And being Iranian, it was looked down upon. It was frowned upon. Definitely, the stigma is more stronger, I think, in our community than anything. Last thing that any parent, especially parents that are doctors or they're accomplished in life, the last thing they want to do is for anyone to find out that our kid has an addiction problem. I don't even want to deem him as an addict. We don't want to call him that. And none of the families and friends can find out about this stuff. We got to keep this under wraps, and it's a secret, right? I believe that I got to a point where I don't really care about the stigma. People can say what they want, but at this point, in this day and age, anybody can become a drug addict. Anybody can become addicted to drugs and alcohol because it's out there. I mean, the neighbor could be. Your kid could be within your own house, right? It's not like it's just happening to a certain demographic or individual. So I myself, on one of my recovery pages, put something up. It was some kind of, I don't even know if it was a meme. I think it was a saying, and I really liked it, so I put it up. And some guy came, and he was like kind of going at me sideways. He was telling me, like, we don't call them addicts anymore. Like, that's definitely stigmatizing him. And I even told him, come on my podcast. I always want to hear people's outlooks. I want you to expand on that a little bit. Why don't you want to refer to people?
I love it because you opened up so many cans of worms, so you got to redirect me and shut me down.
Okay.
But I'll try to be brief, because you brought up the 12-step tradition, and I am aware that when you go in there, you always announce yourself. My name is Joe, or whatever they say.
Yeah.
I'm an addict. Okay, great. I won't get into the history why the term is stigmatizing, but it is, and that's how it's looked at. Interestingly, people that get on the bandwagon of what's politically correct. They themselves become quite sadistic and brutal in the way they treat people that are stepping outside of their view of what's right and wrong. And I saw this a long time ago. But that being said, let's assume the term is stigmatizing, which it is from historical reasons and so forth. There's, I don't do 12 steps. That's not what I do. That's not my world. That's not my reality. Yeah. I'm not going to knock it down. And I'll even say in those traditions and so forth, there's quite a few things that are very valuable if digested the correct way by the individual that will get them in touch with themselves. Mm-hmm. In addition to create good relationships with the objects around them that have, they've created destruction in the path of their life. In that sense, a lot of these traditions are great. The problem with, referring to yourself as an addict or going in the same addict, I always tell folks there's some value to that part itself in this sense. I want you to realize this. Don't call yourself an addict, right? Yeah, don't do that, Henry or Julie or whoever. No. Don't call it. But I want you to realize this. And don't worry about me considering this as a chronic and relapsing, remitting disease that's very complex. No, because that itself might get you paranoid. I simply want you to understand this. This is deeply rooted in your initial neural networks that were created. We call that memory, because if you drive by that 7-Eleven or a severely stressful situation happens in your life, which for various reasons, you didn't learn the tools to cope with them, and this was one of your tools, it's in the memory banks. And that's what actually neuroscientists call that stuff memory. It's a way that you create receptors and binding and all that stuff. So it's and they're deep. So what I want you to do, Joe, is understand, you're coming in here, you're telling me, thank you so much. We just had one recently, and he was talking about his amazing job at the theater. He's bought a car. Things are going great. At that time, I always stop him and I tell him, I'm super proud of you. And every moment that you've had towards this recovery that we're talking about, you've built new neural networks and coping mechanisms. And no matter what happens in the future, you're not going to lose this. At the same time, always remember that in some real sense, this stuff is embedded in the way your central nervous system copes. And I want you to be vigilant of that reality for the rest of your life. It's not a big deal, dude. You're not an addict for life. No, that's not what I'm saying. That's a simplified way of saying it. I'm an addict. And I understand the value of saying that because it keeps a person vigilant, right? Mm-hmm. But let's move away from that language. One, the term addict itself is stigmatizing because of historicity. Two, you're stigmatizing yourself, right? I don't walk around and say, hi, Henry, my name is Fareed. I'm a diabetic. I'm not diabetic, but I don't walk around and say, hi, Joe, my name is Fareed. I have hypertension. Do I do that?
No, you don't.
I don't do that. Does anyone do that? No. Okay. So if we're saying that, let's utilize a disease model. We don't have to say what that is. There's no ontological status that matters here. I'm going to use the model. If it gives me answers and creates a situation that I can make predictions about clinical outcome and intervention, disease model is cool. I don't care what it is, right? It's cool. So it does that for me, all right? So stop saying you're an addict, because now you're limiting your perception. You are Joe. You've dealt with substance abuse in your life. And you know what? Everyone's dealt with different kinds of crap. All this has done, I want you to understand, this has given you tools. This has given you experience. This has been a part of who you are and created the environmental exposures, experiences, pain, tribulations, and victories you've had. Stop calling yourself an addict. You had issues with substances for various reasons that we can get into. It's academic. It doesn't matter. You just need to know that. You've had a difficult time coping and reaching for tools to deal with life. And I remind every single one of them, if you look at cluster B personality disorders, and some of these, something like narcissism, One of the things people don't realize, and that's why these pathologies come up, reality is taxing. Living life is hard.
Right.
Coping with the environmental influences at the same time, trying to place your I for read, on your iPad, into that system of objects in this world and the relationships that you have is hard. Give yourself some grace, dude. You've been coping for 1 year, 2 years, 6 months, 3 months. You've gained tools, and it's not just you. It's tough. And I'm going to tell you right now, it's never going to get easier, and shit's always going to come at you. But you know what? You don't have a choice. You do. You can lie down and die, but that's not what we want to do. The fun is trying to overcome it. And that's why I said, try and move them away from, I'm an addict. No, I go into this long discussion about what
I think what happens too, speaking from experience too, people get sober. Whether they're in treatment or it's recommended that they do go to build a support system, a community, go to this. If you've been using heroin, go to HA, Heroin Anonymous, go to CMA, Crystal Meth Anonymous. I spent a lot of time in those rooms.
Really?
Yeah. I mean, I did a lot of crystal meth. That's another subject, but
we got to get into that.
But I think that the same way, I mean, people get conditioned easy, and I'm not, again, I love the 12 steps saved my life. Most definitely. It helped me find myself and carry on with the steps and help others. I think when you sit in a meeting enough times and it's recommended that you identify as an addict to even be there.
Yeah.
Then it becomes easier for them to just claim that, hey, listen, I'm an addict. You're an addict. I'm an addict. We're all addicts. We're all recovering. We're recovered. Some of us say recovered. Some of us say recovering, but it becomes a way for them to, they don't even really know that they're stigmatizing themselves. They're just basically, that's what we learned. That's what kind of environment we got sober in. So that's just what we call ourselves.
You pointed out to something wonderful there. So that's happening, but there's also something else going on, a phenomenon that's common to human beings. And when I go to the Costa Mesa area, there's they used to call that the rehab riviera. There's all kinds of crap down there. So all of a sudden, a coffee shop, and 50 people might walk by. I know the kids that are in recovery or in the home. You know why? Every goofball is dressed the same, right? So now, you've created a subcultural identification. And that's exactly what I want you to get away from. I want you to find meaning in you. And so it's a natural human tendency. And when you said that about folks, everyone, oh, I'm an addict. So, we are always looking for black and white, simple answers. You know why? Remember, reality is complex. And that's, when you look at the phenomena of sports in America or in the world, why is there popularity? Why? Because we want easy, digestible, identifiable answers. Those guys are the bad guys, whoever the team is. I don't follow any sports. The Raiders are the bad guys. So we're all going to get together. It doesn't matter if, she's an alcoholic. I lost my job. The government's after me, and I'm on my third strike. On this Sunday, the 20 of us are going to get together. We're all going to wear the same jersey. We're going to drink ourselves to oblivion. But you know what? There's, for that moment, folks find comfort and meaning in identifying and getting simple answers.
Right.
And this has translated in places it shouldn't translate into, whether it's politics or the addiction recovery community. And what we should work towards is pushing everybody to create individual identities and comfort in themselves, whatever the past trauma is that made you kind of screwy in the way that you needed that identification and group herd mentality. And what you described kind of is exactly what's going on there, in addition to stigmatizing him without knowing it. Right.
Wow.
And so think about that.
Yeah, I will think about that.
It's a heavy thing.
These conversations are great. I'm enjoying this.
Thank you. Likewise, I'm enjoying it too.
Are there any questions today?
So we had a question back further. think it was Rach K-Bill asked, what are doctors doing to combat the xylazine?
What are doctors doing to combat the xylazine
Yeah, what are they doing to?
epidemic?
Yeah.
If it's even an epidemic.
Yeah, not yet. Combat it in the sense of, I want to make sure I understand the questions. Are they talking about up front before it hits the streets, or what? What they're doing with their
Treating
patients? Yeah, that's a fantastic question. So
how are doctors treating?
I'll be really quick about that. So keep in mind, we don't have human data on this issue, but I can tell you this. I don't want to get into receptor pharmacology too much. It is an alpha-2 agonist. But one of the things this stuff does, I think a lot of people out there know clonidine. The closest thing, even though it's a different drug class, is things like clonidine, Visine. That's actually the same thing as well. There's stuff out there. It's clonidine, except one thing. This stuff only decreases what's called sympathetic outflow from the central nervous system. All that means, guys, all remember the fight or flight thing, right?
Yes.
Bring it down. What's the extreme of that? Sedation, right? So now what you're doing is making it so when they're taking, when someone banks some fentanyl, you're so sedated, you're not aware of choking or the fact that you're not breathing, and your evolutionary responses to breathing aren't there. You're like, man, it's cool. I'm getting, I'm at 60% oxygen saturation and taking 3 breaths a minute. Who cares? That's what it's doing. So that being said, it's hitting alpha-2 agonists in the central nervous system. And initially, I think some of the thoughts was, as far as an overdose of this stuff goes, you got to treat the fentanyl first, right? So you got to hit them with the Narcan and all that stuff. With this stuff, there is no acute antidote for the overdose. I'm going to answer the overdose part first. We don't have that, but you do need to, if you have rescue training and so forth like that, do all that stuff. This is not the place for me to teach. There's a rescue position. You have to be to clear them out. But essentially what it comes down to is clinical support. And so for the clinician that's in that situation, ER guys or whatever, it's really watching your O2, making sure you're breathing, saturation. And there's no antidote. Now, acute withdrawals. Is there acute withdrawals? It seems that from what's going on out there, the acute withdrawals seem to, the majority of them are severe anxiety. Why? Because this is, again, sympathetic outflow. Now, that being said, they last 2, 3, 4, 5 days. But more importantly, when someone stops, we have to remember a large portion of this community has underlying anxiety secondary to other reasons. And a lot of them are also banging meth, which, you can have a, so we need to be careful with that. But really, so far, the very first line they're using for acute withdrawals and so forth is benzodiazepines. You got to be careful with that, because this is not like you're switching someone with what we call a cross tolerance who's been using Xanax for 10 years. Now I got to put him on something like Klonopin volume and consider how long I'm going to taper that. This is acute and short term. So thus far, they're managing the withdrawals with the overdose. There's no antidote, supportive care, take care of the opiates, right? The withdrawals, acute withdrawals in the hospital, they've tried things like clonidine because it hits the same receptor. What they found was as soon as I give you something like clonidine or a related drug, your blood pressure drops to nothing. Now I got to give you blood pressure support because the doses don't match. So clonidine is there to, calm you down, except you need way more clonidine than what the acute withdrawals of xylazine might be like. So it's they're using benzos, low dose, and then as far as the long-term managing, withdrawals and getting someone, obviously you got to deal with the opiate part first. You got to deal with the benzo part first. Long-term, I think the best answer is one has to discern if the anxiety is secondary from xylazine, which we just don't have that kind of data yet, that someone's been using xylazine every day for a year. They come off of it, well, they're gonna have anxiety from the withdrawal of the xylazine for the next 6 months. We don't know that. So I think clinicians should be really careful of the medication they choose, after you deal with the opiates, after you make your decisions about the meth, to discern, is this anxiety truly related to xylazine withdrawals or not? And I hope that answers the questions. We would overdose, acute, and long-term.
There's one more question. Kimmy BBB asks, Dr. B, my question is, how does Tranq Dope cause necrotizing fasciitis?
Yeah, we discussed that quite a bit.
You want to repeat the question, because I don't know that they
so
can
the question was, how does Tranq Dope cause necrotizing fasciitis? And that's that essentially, I think, I don't know. So necrotizing fasciitis is a technical term, right? And that stuff will eat you alive, and you will be dead in 12 to 15 hours. It's you can think of it in terms of soft tissue infections. You can think of it as this extreme end of the spectrum, right? If they're asking that, I don't know. And the answer is everything I said earlier about Tranq Dope causing soft tissue infections. If they're asking in general about soft tissue infections, the answer is still the same. I don't know, except what I discussed earlier, and we talked a lot about that. There could be multiple causes of soft tissue infection. So wherever it is on that spectrum of soft tissue infection, and even if it's necrotizing fasciitis, we don't know. But since I mentioned necrotizing fasciitis, if you're a diabetic, you're at increased risk for that. But that's a different story.
There's some news reports where when they're talking about Tranq, they are saying, and it's a drug that Narcan cannot bring somebody back from. So are they just assuming automatically that this is fentanyl, but it's a form of fentanyl, but Narcan doesn't work for it? Or are they, because they don't really go into depth on these news reports. They're just basically broadcasting, talking about this new drug Tranq, which isn't really that new, but it's become more popular. So what's that all about?
I love you said this, because to me, this is us really, it's a public service, that what you just asked in my mind. And so, and I'll be brief. So opiates, in terms of the central nervous system and respiratory stuff, hit what's called mu receptors, right? Decreases your respiratory drive. In that mixture, now you've thrown xylazine. Xylazine attenuates opiate receptors, but does not have anything to do with mu opiate receptors. It hits other things, but one of the places it hits is called alpha 2 receptors in the presynaptic neuron. All that means is that when you put in Narcan into someone, you might reverse the effect of the opiates, but it won't reverse the effects of the Narcan. And I just touched on that about overdoses.
Yes, you did mention
that. Being said, what I want to tell folks, if you are in a situation where you're going to be traditionally administering Narcan, and if you had no idea about what Tranq Dope is, proceed as before. Give the Narcan, right? You gotta treat that, and then proceed as you would in any kind of emergent situation. I don't want to give any particular directives on how to go about this in this setting, but I certainly want to say this: never look at someone that's probably Tranq Dope, I'm not going to give Narcan. I want to say something minimal, and at the same time keep people doing what they've traditionally been doing, because you certainly don't want to cause an overdose death because someone thinks it doesn't work on that. You shouldn't think that way. You should assume whatever you assumed before, if you were going to assume it's just fentanyl, and proceed as you usually would with the Narcan and the other algorithms that you were going to participate in. Does that help? Does that make sense with
Absolutely. That? Yep. Any more questions?
Got one more.
Okay.
From Dar Duvall.
Okay, what's the question?
It's what help is there for those tapering and withdrawing from benzo/Xanax?
What help is there for those tapering
and withdrawing from benzo?
And withdrawing from benzo, Xanax.
I'll be brief. Xanax?
Yeah.
I'll be really brief on this one as we digress. I will say one thing that is universal on that issue. In my opinion, and I think if you read the literature on the ruling bodies of the planet about how to manage with someone with benzo addiction and taper, there's nobody that's going through a benzo taper that should suffer. This is slightly different than opiates, not that they should suffer, but it needs to be meticulous and delicate in managing a taper of a benzo addict or someone addicted to them, or for whatever reason, if the indication is for them to come off. And whether it's Xanax or whatever, that decision's on the clinician. So I recommend find a clinician that truly understands acute, long-term, chronic, and the potential for you to get off the benzo you're on. And this is a very complex thing that takes a very individualized approach. But one thing that should never happen is the client, for the most part, should not be going through benzodiazepine withdrawals of any kind. That's inhumane. And it's certainly not recommended by any national or international clinical organization that addresses issues such as this. And that's about all I can say in this context here.
Very well. So we had a lot of content, a lot of good stuff to talk about. Is there anything else you want to talk about, or we could wrap it up? And I definitely want to do this more often and talk about many other different types of substances, as well as, you just have such an expansive wealth
opinions,
of knowledge. No, a lot of knowledge.
I appreciate that. And you're great because not only I know you also have quite a bit of knowledge in this area, a lot of experience, but you're very honed in and focused on a very important, you distill the issues into some of the most important things. And it was a pleasure. I love doing this. I do want to do this more often. Our issue and me and Powerham's issues have always been time.
Yeah.
But I would love to do this. I would, maybe even figure out in the future somehow where folks can come on and ask questions
and interact with us,
which they can on StreamYard.
Yes,
we've done that a lot before. But yeah, I had a great time, and I think we did justice here because I think some of this information is important to get out
Absolutely.
there, and it's critical. Potentially save lives or get someone into treatment. And that's what we're all about, huh?
Awesome. Yeah, most definitely. So I want to thank anybody that was listening today on the live stream. Obviously, you'll find us in many different platforms. I have a whole slew of guests lined up coming up now that we have the studio all in effect and in progress. And it's been exciting to have you here, and I will continue to build on our relationship, as I told you the other day when we were talking. And I want to have you back as a regular guest, most definitely, and we'll work together closely.
Likewise, it'd be my pleasure. Again, we got to sort out the time and figure this out. But it was, I really enjoyed it, and thank you for everything you put into this.
Same. Thank you all, and we're going to tune out now. Bye.
See you guys. Peace. Bye, TikTok.